You talked a bit about the adoption of best practice and the spread of best practice, and you said there's a challenge for suppliers and there's a challenge for the NHS. So let's talk a bit about the supplier contribution at the moment. What you sort of hinted at, but let's unpack that. What specifically can suppliers do to make it easier for the NHS to buy whatever they've got on offer? What is it just a matter of price? Or what are there other issues that, other approaches that could get this innovation into the NHS?
Yes, good question. And I think there are a number of elements to this. I think part of this is, and I think this is an obligation on both parts, is to improve the extent to which our suppliers and the NHS view themselves as partners in solving a problem as opposed to providers of a product, which means that the people who are suppliers, the organisations that are suppliers, must come with some expertise about how to make it work. And I think there is and having come from the software industry, I recognise the temptation to want to reinvent something every time you sell it because you can charge the personal services contracts, the professional services contracts against that. But actually we need to start to get to blueprints that we can lift and shift. We need to speed deployment, we need to lower the cost of deployment, and we need to be focused on what the outcome is rather than just the turning on of a piece of technology. But I think there is a step beyond that which says some of these changes are quite large and they're quite long term, and what does a partnership look like, and how do you fund that partnership through an arrangement which says we're going to have a share on the benefits. And I'd like to see the NHS increasingly moving on some of these longer term arrangements to say that there is an upside to both of us of success, and there is a shared downside if we don't make this work. Now, how do we make that feel more like a partnership relationship and less confrontation in the way that it sometimes does?
So one of the things that, and I've been thinking about this a lot about this lately, is the intervention of public services or the state into markets, into supplier markets, is not an area which there's been an awful amount of success here. There does seem to be something happening that does look like the NHS trying to make a market or amend a market, which is you've got the GDE approach where you have these exemplars and other trusts are meant to copy them basically when push comes to shove. There's various frameworks that you're setting out to buy support for ACSs, etc. Yeah. Talking about long-term needs, you're talking about the fact that we, rather than, to use one of Simon's favourite phrases, it's not a question of letting 1,000 flowers bloom. You need to sort of channel down to a smaller number of solutions and have them shared appropriately. If I were a supplier, I might be nervously looking at this approach, thinking what you're effectively trying to do is drive rationalisation and conglomeration in a market so that the NHS has an easier choice to make. Just what's the thinking that you've done around how because there's clearly some advantages as you've expressed there, but there's also some potential dangers there as well, aren't there?
Yeah, there are, and I think it's a good question, and it takes a bit of thinking about. The approach that we've taken is we looked at, if I use the IT example and then I'm going to extrapolate it out, we looked at what happened with the National Programme for IT, which was basically an attempt to standardise through contracts. And then we looked at what the Meaningful Use IT programme in the States did, which took the approach which says, here are some standards, you can pick anything you like, and providing it delivers, we will give you the money. The government will give hospitals the money. And interestingly, the UK approach, which was we're going to standardise down to 2, ended up with a complete fragmentation of the market. And the US approach, which said you can buy anything that works, has basically come back to 3 or 4 vendors. So the market chose to standardise when it was given the freedom to choose, and it chose to rebel when it was told that it didn't have a choice. So we wanted to try and capture a bit of the learning around that. So the approach that we've taken with the digital exemplars is to say, well, firstly, let's build on places where you could possibly succeed, where they already have a history. Let's Try and make sure we've got a spread of vendors and a spread across the country. Let's set a common bar, and where they work, you can choose to take one of those solutions, and we will create a contractual framework. But if you're an innovator newly entering the market, there needs to be a way onto that framework. And if you've been hanging around and not delivering, there needs to be a way off that framework. So the idea was to try and say, let's prove it works, and let's create a pull from the market to go and do it, and a learning which allows us to lower the cost of deployment. And then, interestingly, we've taken much the same approach with STPs and accountable care organisations. Although it's not a sale process, we've said, here are the benefits of being an accountable care system. We will back the ones that are most likely to succeed, and if you want to be one next, you need to find the ones who you can work with as partners in order to learn from them and create a pull environment, as opposed to a traditional NHS restructuring, which is everybody now must look like Frimley, or everybody needs to look like Southampton, because on the whole the NHS is very, very bad at that. So I would like that approach which says, let's let a lot of flowers bloom, but at some point we need to prune back to the ones that work, and over time try and get those the ones that spread, so that we get to scale, because although the NHS is big, it's not massive, and to be successful in this market, if you're a large company, you need to have enough market share to actually be able to continue to innovate and so.
So hopefully after tomorrow you'll have some capital to play with, and you've got plenty of bids, many more bids than the amount of money you're likely to get, unfortunately. But just to finish off on this note, and then I'm going to come to delegates for questions, when you're assessing these bids, and they are for investment in technology or things that require effectively to buy from the private sector in some kind of way, are you going to be looking for where people have effectively copied? You know, they've said, oh, that works somewhere else, so we're going to use it, as opposed to attempting to do it themselves, or do it for the first time. How is that going to affect the judgments you make about which bids get the money?
So if we are lucky enough to get some capital in the budget, I expect a large part of that to be tagged as building an estates capital. And it will be to do two things. One is to rectify some of the problems that have been created by a lack of investment in backlog maintenance, and some of our facilities drifting off the pace of where they ought to be. But some of it will be what we're calling STP capital, but capital to facilitate the transformation. Yeah. And when we get into that space, we're very much looking for our accountable care systems to be the fastest moving, most innovative around the redesign of services, and work out what capital they required in order to be able to change the model of care, and then try and back those models rolling out. But at this point in I think the game, we are looking at quite a lot of capital requests of really good business cases and really good cases that have been stalled for quite a long time. So I think that the pressure to just do stuff that everybody knows is necessary will be pretty high, unless we get very lucky tomorrow.
No, my name's Gavin Boyle. I'm Chief Exec at Derby Teaching Hospitals. And Matthew, you were talking about STPs and ACSs and ACOs, but one of the things that strikes me is that in order to make some of those systems work, the ability to track patients' journeys across the whole pathway, not just in health, but also in their experience of the care sector as well, is going to be a fundamental part of that. And one of the things that really excites me about this particular work, using barcode technology as a means of data capture, is there is that potential opportunity to be able to do just that. So not only would that enable professionals working within that system to have meaningful and useful information about the whole of that individual patient's experience, but also we could use the data generated to do real evidence-based redesign of systems, enabling the development of ACOs and ACSs. So my question is, I'd be interested to hear your thoughts on that as an idea, and secondly, what NHSE could perhaps do to incentivize systems to think about how they might use technology like this to achieve that.
Great, thank you. It's great. It's a great question. So I think that the question is absolutely right. And as we think about joining up systems and wanting to be able to link data together in order to if we could standardise around barcoding for people's homes when social workers went in, when home visitors went in, district nurses went in, when the voluntary sector, if we could get that standard across a pathway, we could actually know what had happened to patients while in their own home, and it would be a mechanism of linking data together and bringing stuff together around a common pathway. So that was part of my point about saying we need to start thinking beyond institutions and out into systems. And I think your STB would be a great place to start saying, because I think not only is the technology interesting conversation, but it would actually provoke the conversation about the redesign of pathways and the use of different professionals delivering care to the same person in and out of people's homes. It would flush out some of the insanities about multiple people going into the same home, and you get a much more interesting conversation out of this than which barcode standards should we adopt. You actually get a conversation about what does care need to look like in a community, and so I think you're absolutely right. And I think part of our responsibility is to be looking for the system-wide solutions. So tell me how this is going to help across the system. So now when people come to me and say, we're looking for some IT money, or which IT systems you buy, hospital chief executive say, which IT system? I say, it's the wrong question. The question is, who are your partners for the future and what technologies are they using? And should you not be standardising? Should you not be adopting the same tools? So I think we are and will continue to be sending out the message that we have a strong preference over institutions working in partnership across health and social care and the voluntary sector, and against I have a perfect walled garden and I'm going to make my bit of my institution perfect. Although perfect institutions are good as well.
Do you think that, would you like to see it sort of shake down in the way that it did in the States, where there were about 3 or 4 approaches shared across the developing, over the next 5 years as the country becomes slowly covered with ACSs? Would you say that feels about the right kind of number?
I think single digits is the right number. I think probably in that sort of number is not unlikely over time, but we shouldn't prejudge who the winners of that are going to be or exactly what it's going to look like. And I think that in a way, we ought to be moving on from the point at which IT system are you using is that interesting a conversation, and moving on to the conversation about how are you using it, how are you using the data, how are you redesigning the pathways.
Interesting conversation if you work for an IT supplier.
Yes.
I was just going to pick up on the discussion that we were just having, and saying that the experiment or the pilot that's going on in Manchester actually give us some very good pointers for the future of how systems can work together. I'm looking forward to seeing some results from that.
Okay, thank you. And over there, please.
Hi, my name is Barbara Schaffnicht. I'm from Carl Zeiss. I have a question regarding the Scan for Safety project. Mm-hmm. How well known is the Scan for Safety project and its rollout within the NHS? And are the timelines still being kept up to date that have been prescribed for this rollout?
I think there are some huge opportunities in Manchester. I think Manchester has taken a generational step forward in terms of the integration of its planning and its management. And I was with John Rouse end of last week talking about this. So I think that if there was anywhere that was going to do the health and social care innovation first, I would back Manchester for pulling that off. In terms of how well is this programme known, I think it's increasingly well known. I think, I had colleagues from the digital team here today talking about how we integrate Scan for Health with the GDE programme. So we need to make, I think, and of course, anything that might have some money associated with it gets very well known across the NHS. So in the hospital sector it is. Whether it is seen yet as being a transformational technology for systems in the way we were just talking about, I don't think it's made that breakthrough, and I think maybe that's the mission for the coming year. And I'm not the right person to ask about project plans and timetables. I'm sure there's other people who can do that.
So just to come back on the Manchester point, and as you're right there, Manchester is powering on. One of the challenges, of course, where you've got, we talked, haven't we, about the integration of health and social care and using data to drive that. You've got two partners there. Health, social care hasn't got any money at all, or very, very little money. The NHS has got a bit more money. There's a danger there that because of that asymmetry in finance and funding flows, etc., that one part of the system becomes built up on steroids and the other one is not so effective. What's the NHS's responsibility? What should it, out of its own self-interest, what should it be doing to help sure that there is the appropriate investment in social care and other information streams that it needs, along with its own? Because if it simply looks after its own data and its own information streams, it won't get the kind of results that it needs, will it? It needs to look beyond its boundaries and possibly fund beyond its boundaries.
Yeah, I think that's a fair question. And what I'm seeing in a lot of the STPs is that this is conversation has moved beyond the NHS needs to help social care do something for its own self-interest to this is actually about the health and care of a population, and people are motivated by that and they recognise they're doing it within constrained funds. But where you get to that point, there are mutual self-interest in the sharing of data that will help social care and help the NHS, which is an economically sensible investment for both parties to make, as in it pays for itself and it delivers quality. And where it's being come at from that angle, I think we are getting good partnership working. Where the NHS goes to social care, even if it says I'll pay for it, says I need you to do this and here's some money to make it happen, that's not the partnerships that create the set of transformations that we need.
Hello, I'm Eric Gatlin. I'm from North Bristol Trust. My question, I suppose, is I've heard 3 or 4 different things today. So we've heard very much about what's in it for the patient, which is absolutely the right thing. We've got lots of examples over the next day or so about what people are doing at the moment, lots of change that people are making, what we can do, and then we've heard a lot about the big picture stuff of where this is going. I suppose the bit that's going through my mind, being an organisation that's kind of got 101 different things on its agenda, how we get this started and how we get that scale and pace quickly, because I can see exactly the vision of what we're talking about, integrating, using all the information to drive forward new care pathways, new ways of treating patients, and particularly in a city like Bristol, not dissimilar to Manchester. There's lots of different providers, lots of different competition around at the moment. And then how do we really get all this started when we've just got lots of enthusiasts and lots of small-scale stuff, and how we get that scale and pace quick? Because I think it's the pace issue that's the real issue that we've not really focused on that much so far.
Yeah, I mean, there was a point made at last week's summit that I can't remember, I think it was Ruth Carnell who was saying that she had seen plenty of examples of, she had seen some examples of where change had been achieved at scale, but none at all where they had been achieved at pace and scale. And there is a sort of ticking, 5-year forward view. It's called 5 years, isn't it? So therefore the clock is obviously ticking on that. And the pace is, we've talked about scale, the spread being a challenge, but pace is one of the challenges that the NHS has often struggled with as well. So that's very interesting, isn't it, about how the current approach is going to do what hasn't happened in the past and get things spread, not only get things spread, but get them spread quickly.
Yeah, and I think it's a great question. I know North Bristol reasonably well, and you have plenty of challenges to keep you busy out there. What I think the core to this is to have a bigger picture of what's trying to be delivered, and that if you take a single project like GS1 project as a project in its own right, there are so many single projects that they can't all be driven at the pace and to the scale, so they end up getting siloed. The real question is, what is our strategy for driving cost out of the organisation? And if a significant part of it is improved patient flow, better materials management, then this is part of that project, and it becomes something that's owned by the board, and its job isn't to deliver £400,000 worth of savings a year, its job is to deliver £10 million worth of savings a year, and this is a crucial part of it. And if you do that, then you start to see scale and pace, because organisations can only support 2 or 3 very major projects, but I think they can support 2 or 3 very major projects. What they can't do is support 30 small projects and hope they will add up to the same as 2 or 3 major projects. So what it requires is the piece of higher mind design thought, which says, so how do these things, how does my IT project, the GS1 project, my review of job plans for consultants or whatever, come together to give me a flow which reduces my bed requirement by 60 or 90 beds in order to get a scale saving. And I think sometimes that's the piece we're missing. We get driven by enthusiasts who drive it into their piece, rather than say, at a corporate level, what do we need to do to move the meter?